Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.in and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the umbilical hernia and para umbilical hernia. Exomphalos, otherwise called omphalocele, is very rare due to failure of all or part of the midgut to return to the coelom during early fetal life. Sometimes a large sac ruptures during birth. When the sac is not ruptured, it is semi-translucent and contains three layers. Outer layer of amniotic membrane, middle layer of Wharton's jelly, and the inner layer of peritoneum. There are two types of exomphalos. Exomphalos minor and exomphalos major. Exomphalos minor. The sac is relatively small and its summit is attached to the umbilical cord. A loop of small intestine or Meckel's diverticulum has been included in the ligature applied to the base of the umbilical cord containing this protrusion. Exomphalos major. The umbilical cord is attached to the inferior aspect of the swelling, which contains a small large intestine and always a portion of the liver. Treatment. Exomphalos minor. It is necessary to twist the cord to reduce the contents of the sac through the narrow umbilical opening into the peritoneal cavity and to retain them there by strapping applied firmly. Though there is a seropurulent discharge from beneath it, the scrapping must not be removed for 14 days. Exomphalos major. Within first few hours of life, operation is to be performed, otherwise the sac will burst. To prevent the further distension of the contents, the infant should not be fed. Few infants with a burst sac may survive following immediate operation and prompt treatment. A blood transfusion may be needed. Operation. The abdominal cavity is very small as most of the contents of the sac have never been housed within the abdominal cavity. It is necessary to create a flap of skin by undermining the subcutaneous tissue on either side so that the flaps can be brought together over the sac. If necessary, relaxing incisions must be made in the loin to allow closure. To relieve of prevent distension, it is advisable to carry out aspiration through the indwelling gastric tube for several days following operation. If the patient survives, the construction of this protective cutaneous coverage repair of the hernia can be delayed for months or years. At the second operation, it is surprising to find that the peritoneum and muscles can be drawn together and closed in layers. Congenital umbilical hernia. Rarely a well-developed umbilical hernia is present at birth, may be due to the intrauterine epithelialization of a small exomphalos. Umbilical hernia of infants and children. This is umbilical hernia is a hernia through a weak umbilical scar. Usually the umbilical hernia is symptomless, but when the size increases by crying etc. cause pain. Small hernia are spherical. Those that increase in size of the hernia tend to assume a conical shape and are present apart from crying. Strangulation and obstruction below the age of 3 years is not common. Treatment. Conservative treatment is successful in a majority of cases. Masterly inactivity. When the hernia is silent in majority of cases, hernia will disappear spontaneously during first few months of life. So, assurance of the parents will be sufficient. Herniorrhaphy. If umbilical hernia is not resolved in 3 months, operation is required and it should be carried out preferably at the age of 2 years. Steps of operation. In infants, a small curved incision is made immediately below the umbilicus. The skin cicatrix is dissected upwards and the neck of the sac is isolated. After ensuring that the sac is empty, it is either inverted into the abdomen or is ligated by transfixion and excision. The defect in the linea alba is closed with 2 absorbable sutures. Para-umbilical hernia of adults or supra-infra-umbilical hernia in adults. In adults, the umbilical hernia does not occur through the umbilical scalp. The umbilical hernia in adults is a protrusion through the linea alba above the umbilicus or occasionally just below the structure. If it enlarges, it becomes rounded and oval in shape with a tendency to sag downwards. Para-umbilical hernia increases steadily in size and frequently attain a very large dimension. The neck of the sac is remarkably narrow as compared with the size of the sac, and the volume of the contents, which consists of greater omentum, sometimes accompanied by small intestine, and alternatively a portion of transverse colon may be there. In long-standing cases, the sac sometimes loculated due to adherence of omentum to its fundus. Clinical features. Women are more prone to get para-umbilical hernia between the ages of 35 to 50. Important factors are obesity, flabbiness of abdominal muscles, and repeated pregnancy. These para-umbilical hernias soon become irreducible due to the omental adhesions within the sac. Pain. A large umbilical hernia causing a dragging pain by its weight. Due to traction of stomach or transverse colon, gastrointestinal symptoms are common. Sometimes there is transient attacks of intestinal colic due to subacute intestinal obstruction. In old-standing cases, intritigo of the adjacent surface of the skin. Treatment. If not treated in time, the para-umbilical hernia increases in size and its contents become irreducible, so strangulation may occur. So operation is needed in all cases without delay. If the para-umbilical hernia is symptomless and the patient is obese, operation can be postponed till the weight is reduced. The laxity of the abdominal wall during early purpurium makes it a most opportune time to perform umbilical herniorrhaphy. MAYO'S operation. Around the umbilicus, a transverse elliptical incision is made to expose the neck of the sac. The subcutaneous tissues are dissected off the rectus sheath to expose the neck of the sac. The neck is incised to expose the contents. Intestine is returned to the abdomen. Any adherent omentum is freed and ligated by transfixion if it is bleeding. Excess adherent omentum can be removed with the sac if necessary. The sac is then removed and the peritoneum of the neck closed with catgut. The aponeurosis on both sides of the umbilical ring are incised transversely for 1 inch or more, sufficiently to allow an overlap of 3 inches. 5 mattress sutures are inserted into the aponeurosis. When this mattress sutures has been tied, the overlapping upper margin is stitched to the sheath of the rectus abdominis and the midline aponeurosis. Before stitching, the flap is flap in position. It is important to denude this area of fat. In obese patients who ooze blood and liquid fat, a drain is provided at each end of the wound. The subcutaneous fat and skin are then approximated with deep sutures. If the patient has a tendency to bronchitis, it is wise to prescribe antibiotics and breathing accessories. If the surgeon is not satisfied, he may employ facial flap operation. Lipectomy. If the patient is having large pendulous fat, with a great advantage be combined with a lipectomy by fashioning the incisions to embrace a large area of the fat, laden, superficial layer of the abdominal wall. Strangulation of a para-umbilical hernia. It is common in adults due to narrow neck and fibrous edge of linea alba. Gangrene is liable unless early operation is carried out. Operation. If a portion of transverse colon is gangrenous, it is exteriorized by Paul-Mikulicz method and the gangrenous portion excised. If the ring is large enough to transmit the colon unhampered, it is left alone, otherwise it is enlarged. It is important that the small intestine be thoroughly scrutinized, as a small loop may have been trapped and slipped back when the constriction is relieved. If a non-viable gut is overlooked, peritonitis quickly supervenes and the symptoms are ascribed to post-operative discomfort. The condition may slowly deteriorate, hence very much care is necessary. That's all about the umbilical hernia and para-umbilical hernia, and in the next video I will discuss about some other disease. Thank you.